Okay, welcome back, everybody. It's my great pleasure to introduce our afternoon speaker, our second Foundations session. The speaker is Dr. Jason Busse, a man who wears many hats at McMaster University, the Associate Director of the DeGroote Center for Medicinal Cannabis Research, also the Director of Research for the Center of Excellence on Chronic Pain, and the Director of the National Pain Center. Dr. Busse is also an associate professor in the Department of Health Evidence and Impact and the Department of Anesthesia. He's published more than 200 peer-reviewed publications and was the lead author of the 2021 BMJ Rapid Recommendation for Cannabis and Chronic Pain. So we're in very good hands to learn about the state of the evidence when it comes to medical cannabis. Thanks so much for speaking today, Jason.
Yeah, thank you so much, and happy to round out what's been a great day of talks. So as you heard, I'm going to be talking a little bit about what we know about the potential benefits of medicinal cannabis. And to begin, I do have a few disclosures, but I have no for-profit relationships to declare. My financial disclosures are some grants from CIHR to study the effects of cannabis on chronic pain. In terms of a background, cannabis has been legally available for select medical conditions in Canada for a couple of decades now, but it has been difficult to acquire until more recently. Licensed healthcare practitioners can provide authorization for patients to acquire medicinal cannabis, but most of the available products do not have a drug identification number, and so they can't be prescribed, the exception, of course, being synthetics. The number of Canadians authorized to use medical cannabis has been sharply increasing. It went from almost 24,000 in June of 2015 to over 370,000 by September 2020. And we know from a number of studies in Canada that there are a number of individuals using cannabis therapeutically that do not have authorization. So the true number is quite a bit higher. Now, you might anticipate with such a high rate of formal authorization and a high rate of informal use for clinical conditions that we would have a fairly robust evidence base underneath medicinal cannabis. And indeed, when you conduct surveys of populations, this is a large survey that was done in the USA a few years back, asking individuals from the general population what they perceived about risks and benefits of cannabis. The vast majority believed that there were health benefits to using cannabis, 81%. 9% believed it had no risks whatsoever. 22% advised that they believed it was not addictive to use cannabis, or it could not become addictive. Of course, it does have risks. There's no active substance you can consume that has only benefits without any risks. And we know, of course, you can develop a cannabis use disorder. The prevalence is an issue of some debate, but cannabis can be addictive. So at least from this survey, and certainly from others that I'm aware of, the general population tends to have somewhat of an enthusiastic view towards cannabis, which may not be based entirely on the evidence that we have, and they may tend to underestimate potential harms. So what are potential therapeutic areas where cannabis has been shown to have a positive effect? Well, there are a number of sources you can go to for this. If you go to the internet, you'll find many, many websites that purport innumerable benefits. This is one such website, just one at random, nothing particular about it. This is a practitioner in the US who advised he's been studying the impact of medicinal cannabis for some years, and he was kind enough to provide a list of conditions for which cannabis has been shown to be helpful. Here are some excerpts from that list. You see it begins with genital herpes. We have number of cancers here, Graves' disease. We have impotence here, writer's cramp, stuttering, anorexia nervosa, migraines, Bell's palsy, any kind of neuropathy, TMJ syndrome, gastritis, both acute and chronic, diverticulitis, again, premenstrual syndrome, all kinds of arthritis here, ankylosis, disc disease, It goes on, fibromyalgia, we have Marfan syndrome, cough, hyperventilation, any kind of knee, ankle, or foot injury. It goes on. I ran out of room on the slide to keep cutting and pasting. So this is clearly an enthusiastic portrayal of the potential beneficial effects of cannabis. You might be hard-pressed to find a condition that is not represented on this list. But there is a competing perspective out there. This is an article that was authored in the Wall Street Journal a few years ago by a respirologist. And I think the first couple of sentences here well encapsulates this clinician's impressions. And again, so does the title. If weed is a medicine, so is Budweiser. He states actual medicines have research behind them, enumerating their benefits, characterizing their harms, ensuring that the former supersedes the latter. Marijuana doesn't. It's a toxin, not a medicine. It impairs judgment and driving ability. It increases the risk of psychosis and schizophrenia. And smoking it damages the respiratory tract. So we have two dramatically different impressions of the same agent here, cannabis. So why is there a suspicion that there could be therapeutic use? Well, we do have a number of states in the US, and you heard in one of the earlier presentations today that although cannabis is illegal for use at the federal level in the United States, it is legal for therapeutic use in a little over 30 different states. It's legal for recreational use in around 14 states as well. But we have a number of observational studies that have shown that when cannabis becomes legal, there is a reduction in the use of prescription drugs. And in particular, we see a reduction in drugs that are typically used to treat anxiety, major depressive disorders, nausea, pain, sleep disorders, and muscle spasticity. Now, again, this is observational data. We can't assign causation to this, but there appears to be at least the possibility that use of these medications has declined when cannabis becomes available, because some individuals find that it is an effective treatment for conditions that they would otherwise be using these medications for. And indeed, there are certain areas, such as the treatment of certain forms of pediatric seizure disorders, where we do have compelling clinical trials that isolated cannabinoids, in this case, CBD, cannabidiol, has shown an effect above and beyond placebo for reducing frequency and intensity of seizures. The evidence was sufficient for the FDA to approve Epidiolex as the first medication that was derived from the cannabis plant. This is one of the trials that came out in the New England Journal of Medicine, and it's a little difficult to see here because of the printing. But I thought it might be interesting to point out that when you look at the proportion of patients that had at least a 50% reduction in compulsive seizure frequency, it was an impressive 43% with cannabidiol, but perhaps impressive as well, it was 27% amongst the children that were randomized to receive placebo. So again, important that we have observational data, which can give us information on the potential benefits of cannabis and cannabinoids for treating different conditions. But this trial well illustrates that there's a potential high rate of non-specific effects with so many of the conditions that cannabis is used to treat, from pain to seizures to disrupted sleep. Very important to have randomized controlled trials so we understand if the specific benefits are greater than a sham intervention. This is another one of these trials that came out that supported the FDA's position on this first cannabis-based medicine. So we do have areas where cannabis has shown a benefit and is currently available for treatment. What about other conditions? Well, this is a Cochrane review, which was just published a little bit earlier this year, looking at the potential role of cannabis or cannabinoids for treatment of symptoms associated with multiple sclerosis. And what they found was, compared to placebo, nabiximols probably reduces the severity of spasticity in the short term in people with multiple sclerosis. They say probably because the certainty of evidence at this point is low to moderate, but there is a promising signal there. And they were unsure about the effects on chronic neurologic pain and health-related quality of life. What about psychiatric disorders? Well, this is a review that was published a few years ago in BMC Psychiatry. And what they found was a number of isolated, so single studies that reported positive effects, potentially supporting cannabinoids, namely cannabidiol, for reducing social anxiety, with mixed, mainly positive evidence for adjunctive use in schizophrenia. And they found some case studies that suggest medicinal cannabis may be beneficial for improving sleep and post-traumatic stress, but they acknowledge that the current evidence is quite weak at present. We updated the evidence for the potential effects on sleep in a review that has just come out a couple of months ago. And we found moderate certainty evidence that medical cannabis and cannabinoids may improve impaired sleep, but the magnitude of benefit is likely to be small. In other words, it probably won't work for most individuals, but it appears to have some beneficial effects for a minority. Difficult to say at this point who that subgroup is that are likely to benefit versus the majority that don't appear to. What about increasing appetite? Cannabis has long been postulated as an aid to individuals who are dealing with HIV and are losing weight rapidly. This systematic review that again came out this year found that the evidence is limited. It was inconclusive at this point to be able to determine if there is a positive effect. So again, we have a lot of use of cannabis, and it's a growing number of individuals in Canada and elsewhere that are turning to these products for therapeutic benefit, but we have a lot of uncertainty. And you might ask yourself, well, how is it that medicinal cannabis has been available for therapeutic use for 20 years in Canada, and yet the state of the evidence appears to be so limited in so many areas? Well, this is because as opposed to most clinical interventions that are made available, cannabis was not brought about as an option because we had existing evidence demonstrating where it is effective and where it is not, so much as on the basis of compassionate grounds. There were a number of legal challenges that essentially has made this available, and we are now trying to do the studies to determine where it has potential for benefit. Now, what conditions are individuals using cannabis for when they turn to it for therapeutic purposes? This is a recent analysis out of those that were authorized to use cannabis in the United States. The graph is fairly self-explanatory here. You see there is some use for multiple sclerosis or post-traumatic stress disorder, chemotherapy, induced nausea and vomiting, but far and above beyond all other indications, people are turning to it for relief from chronic pain. So this was a study done on a little over 800,000 medical cannabis license holders in the US. And chronic pain was the qualifying condition reported by almost 2/3 of all patients. So this is the dominant condition. So what do we know about the impact of medical cannabis or cannabinoids on chronic pain? Well, there was a guideline that was published a little over a year ago from the UK organization NICE, the National Institute for Healthcare and Excellence, and they made a strong recommendation against the use of medical cannabis for chronic pain. A little bit more recently, the International Association for the Study of Pain embarked on a series of evidence syntheses, and they put out a position statement in 2021 advising that they do not endorse the general use of cannabinoids to treat pain due to a lack of evidence from high-quality research. So here you have two large, well-respected organizations coming out with strong recommendations against the use of cannabis for chronic pain. Is that now case closed? Well, we weren't sure. So we decided to look at this issue ourselves, and in particular to address the clinical question that you see listed up here. In adults and adolescent patients living with cancer or non-cancer chronic pain, should we recommend or suggest a trial of medical cannabis or cannabinoids versus continued care without such treatment. And when we embarked on this, we set out with an understanding that we would either be making a strong recommendation or a weak recommendation. A strong recommendation, whether it is against, right? This is what NICE and IASP did, means that almost all informed patients, given the information, would choose not to embark on a trial of medical cannabis. In favor would be the opposite. Almost all informed patients would. And a weak recommendation means that there's uncertainty. Some patients, given the information, might be interested, some may not. So the weak recommendations are more of a candidate for shared decision-making, although there is an element of shared decision-making, even in the case of strong recommendations. So what distinguishes a weak from a strong recommendation? Well, we use the grade approach, which you heard a little bit about this morning. And with the grade approach, in order to make a strong recommendation, either for or against an intervention, there needs to be a clear imbalance. So there needs to be either evidence that the benefits clearly outweigh the harms, or evidence that the harms clearly outweigh the benefits. We have to have confidence in the evidence, usually requiring in grade terms either moderate or high certainty evidence. And we have to believe that patients would largely make the same decision in almost all cases given that information. So we need to understand the evidence, we need to understand patient values and preferences. And if they all align in the way that I've put out here, we can justify a strong recommendation. We make weak recommendations when there is more of a close balance between the benefits and harms. They're more aligned. Therefore, the decision is going to be more preference sensitive. Do the patients value the small chance of added benefit, or do they value that sort of harm that they're going to be closely trading off against? Perhaps we have lower certainty in the evidence, and we don't know if we can believe the estimates. And we would believe that given that information, that there would be an appreciable variation in what patients would choose. Some patients might be interested, some patients would not be interested, but it's uncertain before we ask the patients, and we anticipate a fair bit of variability. So those are the circumstances under which we can make a strong or a weak recommendation. We then established a guideline panel. We decided the perspective of our guideline was going to be the patient perspective, and we engaged 21 panel members. That involved clinical experts, methodologists, and 3 patient partners that were living with chronic pain, including a veteran, one that had never tried medicinal cannabis, one that had tried cannabis but found it was not helpful, and another that had tried medical cannabis and found that it was helpful and were continuing to use. So we tried to represent a variety of opinions, a variety of perspectives, but we ensured that no one on the panel had any substantial financial or intellectual conflict of interest. Financial conflicts of interest are easy. Someone making money off a certain product, or do they have shares in a company that makes medicinal cannabis? Intellectual conflict of interest is a little bit more challenging, but I would argue equally important. And what I mean by that is if an individual has made very strong statements or published very strong statements, that they've made up their mind on this issue, that there's not a debate in their minds anymore. And in such cases, we would not take that person on the panel because we would perceive that their conflicts might influence their voting on the recommendations. I mentioned before we want to understand values and preferences. So to do that, we conducted a systematic review for studies that reported the values and preferences of patients with chronic pain who either do or do not use medicinal cannabis, as well as the values and preferences of their carers on the relative values or importance of benefits and harms related to medicinal cannabis use, attitudes and preference for or against medical cannabis, different administration routes and formulations, and factors that influence their decision-making, whether or not to embark on a trial of medicinal cannabis or to avoid such a trial. And we found 15 studies eligible for review, all reported patient values and preferences of adults. 9 enrolled patients from the US, but we did have some representation from the UK, Israel, Canada, and Australia. They're all fairly recent studies conducted from 2000 onwards. and both cancer and non-cancer chronic pain patients were represented. And we found moderate to high certainty evidence that many patients valued the effectiveness of medicinal cannabis for symptom management, even when experiencing adverse events related to concentration, memory impairment, or fatigue. There was a greater preference for products that were either high in CBD or had a balanced ratio of THC to CBD versus high THC for those that used cannabis therapeutically. We found their use of cannabis or non-use was influenced both by positive social consequences and also negative social consequences, stigma surrounding cannabis use, because it has such a long history as a recreational product and still is used, of course, for recreational purposes. Concerns about medical cannabis included side effects, addiction, tolerance, losing control, or acting strangely, and individuals that had a greater concern about these types of side effects were less likely to be interested in medical cannabis as a therapeutic agent. We found low certainty evidence that there was highly variable attitudes towards medicinal cannabis amongst individuals who lived with chronic pain. And patients were motivated to use medicinal cannabis to reduce use of prescription medication and felt that it was safer than, in particular, opioids. Interestingly enough, neither the NICE guideline or the IASP work systematically explored patient values and preferences. And we have published this paper in BMJ Open if you're interested in a more details. We then conducted a systematic review of randomized trials of cannabis for chronic pain. We found 32 trials, 28 on non-cancer chronic pain, 4 on cancer-related chronic pain, all adult populations, median age of 54. Length of follow-up range from 28 to 140 days. In fact, our minimum cutoff was 28 days. We didn't consider trials with shorter follow-up than that. Placebo was the most common control, fairly typical for chronic pain trials. And they explored in 5 trials endocannabinoids, cannabinoids that we ourselves make, phytocannabinoids in 20 studies, and synthetic cannabinoids in 12. Mode of administration was typically oral capsules. Number of trials also had sprays. 1 looked at sublingual drops and 2 looked at topical creams. Of interest, no eligible trial explored inhaled cannabis, which is one of the most common modes of administration for therapeutic use. This table is a little bit busy, and I don't expect anyone to sort of read through the full table, but I will highlight one example to give you a sense of how to read this. So this is the outcome, pain, on a 10 centimeter visual analog scale. 27 trials reported on the effect of medicinal cannabis versus placebo, just shy of 4,000 patients. The minimally important difference in terms of pain relief is 1 centimeter. So that's how much relief is required for patients to consider the intervention to be helpful. Follow-up 1 to 4 months. If we look at the treatment effect, the weighted mean difference on that continuous 0 to 10 scale was 0.5 centimeter, which seems fairly small, and it's below that minimally important difference that I've highlighted. But we then converted that to the risk difference for the proportion of patients that would be likely to achieve that minimally important difference in pain. And it turns out that was 10%. So that means 10% more patients that received medicinal cannabis in these trials versus placebo reported a benefit in pain that was important. We had moderate certainty in the evidence. And our summary was that cannabis probably results in a small increase in the proportion of patients experiencing an important reduction in pain. You can see when we get to physical functioning, we also had a statistically significant result, but the risk difference is now smaller. It's 4%, meaning that you would have to treat 25 patients with chronic pain with cannabis versus placebo for 1 to report an important benefit in functioning. When we look at emotional functioning, we found no significant difference between cannabis and placebo, and these are both high certainty evidence. Now, what did the NICE guideline say about the effects of medicinal cannabis on pain? Well, they found a very similar result to us. They said treatment effect was modest, average improvement of about 0.4 on a scale of 1 to 10. And in fact, their actual result was 0.44 on that 10-point scale. Well, quite similar to what we had. Now, they only pooled 11 trials. We pooled 27, but our effects were quite similar. We found a 0.5 centimeter reduction. So why did they conclude that that effect was likely to be unimportant versus our conclusion that there are a minority of patients that would achieve an important benefit? The difference is they stopped their analysis with an average effect. That's a little bit like taking the average height in a room and saying everybody in the world is 5'7". What we're curious about, because not everybody will achieve the same response with most interventions for chronic pain, I would say, there's variability. Some get more of a response, some get less. Cognitive behavioral therapy works for some, it doesn't work for others, for example. So we took it a step further. We modeled the risk difference of achieving an important benefit. That was 10%. And when we looked at the information from our values and preference work, we learned that individuals that live every day in chronic unrelenting pain are likely to consider the possibility of a small chance of important pain relief as fairly worthwhile. So again, we didn't stop at the average effect. We looked at a responder analysis, and it was on that basis that we focused our recommendation. What did the IASP say about the effects on pain? Well, they basically said, we found an effect, but we didn't believe it because the evidence was very low certainty due to risk of bias. Now, I showed you that we had moderate certainty in the evidence. So why did they conclude very low and we thought it was moderate? Well, we looked at risk of bias the same way that they did. And sure enough, we did find that 63%, only 63% adequately generated the randomization sequence. So we had about a third of trials at potential risk of bias for that issue. And we found that almost half the trials reported large amounts of missing outcome data. So we also found some risk of bias issues, but we did something a little different. Instead of downgrading the evidence because there was a risk of bias, we looked to see if that risk was realized. And the way we did this is we conducted a subgroup analysis in the first case. So here we have 16 trials at low risk of bias. Here we have 11 trials at high risk of bias. Now, first off, there was no significant difference between the effects. So we concluded that there was not a subgroup effect. But let's say we believe there was. Let's say we only looked at the 16 trials of low risk of bias. The effect on pain is larger. Instead of being 0.5 of a centimeter, it's now 0.74 of a centimeter. It's these high risk of bias trials that are actually taking the effect size down. That's the opposite of what we worry about, right? We worry if we're considering studies at high risk of bias that they might exaggerate the treatment effect. In this case, they're attenuating it, but again, no significant difference with our test of interaction. So we pooled across all the trials and we said there was a risk of bias, but it wasn't realized. What about loss to follow-up? Here we did something called a meta-regression. On this axis, you see the amount of pain relief. So this is 0 is no pain relief. Here's -1 centimeter, -2 centimeters, and here's the proportion of loss to follow-up. And what you can see is the more follow-up, the more patients I'm losing, the higher loss to follow-up, the smaller my treatment effect becomes. This is our best fit line. So amongst the studies with the least loss to follow-up, the effect is largest. If I get rid of these studies, I'm once again going to increase the magnitude of the effect on pain. It's the opposite of what we worry about with risk of bias. Again, this wasn't significant. So we concluded that risk of bias did not occur. But again, if we believed it did, and we restricted only to studies that had adequately reported randomization and had low follow-up, we would be reporting larger effects on pain relief. Here are some other outcomes. No difference in role physical between cannabis and placebo. No difference in social functioning. We do see an improvement in sleep quality. Again, it's not large. We see a risk difference of 6%. That means you have to treat about 17 patients with cannabis versus placebo for one to experience a benefit. And we had high certainty in that evidence. The next outcome is quite interesting. This is the ability for cannabis to allow patients to reduce their intake of opioids. Now, when we looked at our result, it was non-significant. Our weighted mean difference, it showed 3 milligrams morphine equivalent less opioids per day for those that had been given opioids versus placebo, but it was non-significant. Now, the NICE guideline looked at this the same way that we did, and they said there is no effect of cannabis on opioid substitution. We rated this as very low certainty evidence. Why did we do this? It came from randomized controlled trials. Risk of bias had not been realized. We rated it as very low because of a critical reason that NICE did not acknowledge. All 4 trials reporting opioid dose instructed patients who were all living with chronic pain secondary to cancer to maintain their dose of opioids during the trial. So of course you're not going to see a difference in opioids being used. Every patient was told not to change their use of opioids during the trial. That is a massive limitation. So we rated down to very low certainty because of that indirectness. In fact, if NICE hadn't highlighted this evidence, we wouldn't have even considered it because it was so indirect. What we then did is we looked at observational literature, and we found 6 studies, 710 patients, and they actually showed that there was a significant reduction in use of opioids when you provided patients with chronic pain access to cannabis, an average of 20 milligrams morphine equivalent reduction per day, which is quite substantial. But again, because it's observational data, we also rated our certainty very low. So at the end of the day, we are not certain whether providing access to cannabis allows people to reduce their dose of opioids, but it is not an established issue by any means. Again, this paper has been published if you're interested in reading more details. I've told you about some of the benefits. What about harms? Well, cognitive impairment. Yes, there is a small significant increase in that risk difference of 2%. It means out of every 50 patients treated, 1 will experience cognitive impairment versus placebo. If you look at vomiting and drowsiness, yes, it's significant. Again, our risk differences are quite small, 3 and 4%. So the large majority of patients will not experience an excess of these adverse events compared to placebo, but a small proportion will. Dizziness is a bit of a different story. If you look at the short-term follow-up trials, the risk difference is 8%. If you look at the studies that followed patients for 3 months or longer, it goes up quite a bit. You have at least 1 in 3 patients that will report at some point during that trial a transient episode of dizziness. What about impaired attention, diarrhea, nausea? Again, yes, there are statistically significant increases in those risks. Again, the risk differences tend to be quite small, from 3 to 5%. So the large majority of individuals will not experience an event more than they would on placebo, but there is a small proportion that will. And again, we've published this in the British Medical Journal last year if you want to read the full report. What about more long-term, more serious adverse events? Cannabis dependence, road traffic injuries, falls, suicide, suicidal ideation. Unfortunately, there is evidence on this, but it is all of very low certainty. We have very limited information. What we have doesn't suggest that there is, for most of these, it doesn't appear as if the risk is a lot more than not having access to cannabis for individuals with chronic pain. Again, this is not recreational use. This is therapeutic use for chronic pain, but we cannot say with certainty what the true risks are of these more long-term and serious adverse events. We just don't have the evidence to say. Now, to whom does our recommendation apply? Well, as I mentioned before, no trial eligible for our systematic review explored the effect of inhaled forms of medical cannabis or enrolled patients involved in palliative care. And as a result, our recommendation will not apply to those populations, which is a limitation. Now, when we looked at the trials that were eligible for our review, they largely excluded chronic pain patients with concurrent mental illness. And again, this is not uncommon in chronic pain research, unfortunately. They also largely excluded those receiving disability benefits or involved in litigation, and they did not report the representation of veterans. Because of that, the generalizability of our findings to those populations is uncertain. We have no reason to believe that the benefits would be systematically different, but we can't say for sure. So going back to the grade approach, again, recall that looking at the evidence, NICE and the International Association for the Study of Pain made strong recommendations against. And again, in order for us to do that, we have to believe there is a clear imbalance, right? A strong against would mean the harms clearly exceed the benefits. We'd have to have high confidence in that evidence, at least moderate certainty or higher. And we'd have to believe that given that information, all patients would make, or almost all patients would make the same choice. I'd argue, doesn't seem as if those criteria are met. In fact, the ISP specifically claimed they were plagued by very low certainty evidence. So again, we make weak recommendation when there's more of a close balance. There's the possibility of some benefits on pain, function, and sleep, but for a minority. There's the possibility of some transient harms, some transient nausea, some transient cognitive impairment. But again, it affects only a small minority of individuals that are taking cannabis versus placebo. We're not in a situation where we have lower certainty, except when it comes to the long-term harms. But certainly with the benefits and the harms reported in randomized controlled trials, we actually had moderate or high certainty evidence. And again, from our work on values and preferences, we learned that patients are likely to make different decisions depending on their personal context and situation. And so according to this, it was quite straightforward for us to make a weak recommendation. Now, should it be a weak recommendation in favor or a weak recommendation against? We worked with our patient partners. We looked at the evidence that we had available, and we decided to make a weak recommendation in favor of offering patients who live with chronic pain a trial of non-inhaled medicinal cannabis or cannabinoids versus if their standard care was insufficient. So there are a number of caveats. This is an infographic produced by the British Medical Journal, clearly outlining to whom the recommendations apply, the populations to whom we are less certain, and of course the populations or modes of administration to which our recommendation cannot apply because of limitations in the evidence. So in summary, when you're looking at this very large and complex field of the potential benefits of therapeutic cannabis, CBD has been established at this point for showing modest benefits for certain pediatric seizure disorders. It's now a licensed medication available in the US. I anticipate in the not too distant future, it will become available in Canada. Medical cannabis may reduce spasticity associated with multiple sclerosis. Certainty of evidence at this point is only low. It may help reduce chemotherapy-associated nausea and vomiting. Again, we don't have high certainty evidence yet. And it does appear as if medical cannabis may provide modest benefits for a minority of people living with chronic pain. And again, we looked at medical cannabis, and I clearly recognize, and you've heard from a lot of the great speakers we had today, medical cannabis is not a single product. There are, well over 100 different unique cannabinoids. We did try to look for subgroup effects based on mode of administration, based on type of cannabis. Not enough evidence for us to clearly say at this point, so we've taken more of a broad category approach to it. And again, for other conditions, and as you saw from the one list I put up, there are many, many conditions for which an effect is postulated. The effectiveness of therapeutic cannabis at this point remains uncertain. So new research and new evidence is very likely to change how this product is used for other indications. And with that, I'm happy to take any questions.
All right. Thank you, Jason. We have a question right now in the Q&A box from Kayla. Hi, Jason. Do you have any idea as to why patients with concurrent mental health issues would be excluded from a lot of those trials? And are there ways to design studies so they could be included?
There absolutely is. One of the challenges when people embark on clinical trials, maybe particularly if they're industry funded, they are quite keen to show the intervention works. The way you do that is by enrolling uncomplicated, otherwise healthy people that have better prognosis. So you avoid people that have concurrent mental illness. You avoid people that are involved in litigation or receiving disability benefits, even though it is very common for these issues to be present in real patients that seek care for chronic pain. So the unfortunate reality is trials are often designed to exclude the more difficult patients in order to have a greater chance of showing a benefit. And this means we have to be conscious of that when we try to apply the results to patients in the real world that might come with additional features. So should we have more trials that enroll more representative patients? 100% yes. But we have to have investigators that are willing to take the risks associated with that, which is maybe finding that the product doesn't tend to work particularly well in more complex patients.
Great. Are there any other questions? There's definitely a lot of information. All right, a couple more. From Tom, has there been any research regarding the differences in treating neuropathic pain versus arthritic/inflammatory pain? I also recall treating a patient with a stroke history who suffered from central pain related to the stroke with some improvement. Any thoughts?
Yes, great questions. If you look at one of the original, I think the only existing Canadian guidance right now, they made a statement suggesting cannabis might be a third or fourth line option only for individuals with neuropathic chronic pain that hadn't responded otherwise. We did look at this. We looked at subgroup effects based on neuropathic pain, nociceptive pain, which is arthritis, and also central pain, things such as fibromyalgia. We found no evidence for a subgroup effect. So I'm not saying that cannabis might not respond or provide different effects based on the type of chronic pain condition, but we didn't see evidence for it. And when we talked to a lot of the clinical experts involved in our guideline panel, they acknowledge that the longer someone lives with chronic pain, the muddier those waters become about a clearly defined, discrete diagnosis. They vary often that a lot of their patients, yes, they had some elements of neuropathic pain, but 5 years into their chronic pain journey, there were other features that were likely complicating. So I can't say with certainty. We did look for those subgroup effects. We did not find evidence. So we reported the effect consistent across different types of pain conditions. Future evidence might change that, but the evidence we had did not give us credibility to make separate condition-specific recommendations. In terms of the treatment of chronic post-stroke pain, that is one of the reasons that McMaster is slowly being renamed Michael G. DeGroot. Michael DeGroot has been an incredible benefactor, supporter of research efforts, supporter of McMaster. And one of the reasons that he went into this journey is he himself unfortunately suffered a stroke. And he was left with persistent post-stroke pain. He had the resources to pursue any and all therapy you can imagine. And one of the things that he found provided him with some relief was medical cannabis. So it really was his personal experience that in large part led to the development of the Center for Medicinal Cannabis Research. So again, there's these areas for potential. There's powerful anecdotes that we have to listen to. We have to listen to patients. We have to hear these stories. And then we have to undertake rigorous research to see what types of treatment claims we can clearly defend. So a lot more work to be done, clearly, but this is what we know at present.
Question from Pat. Is your university offering cannabis studies or trials for 50 plus patients, specifically around suffering from chronic pain?
We absolutely want to move into that realm. It is another talk in and of itself to talk about the challenges that we have faced and managed in our sort of journey to get a clinical trials license. We have recently been successful in doing so. Our initial trial is going to be look at preventing chronic pain after total knee replacement, but there are a number of trials that we want to get active in. So if you are interested in hearing more, you see the website on this last slide here for the Cannabis Research Institute. We are always interested to sort of help link up interested parties with researchers that might be doing work that they are interested in. So we don't have those trials underway yet. Would we like to do them in the future? Absolutely.
Question in the chat from Julia. Are there currently any guidelines for conducting research with cannabis to generate more standardized studies and reduce bias?
So there are very clear guidelines about optimal strategies to conduct clinical trials in general. There is very clear guidance about trials of chronic pain specifically. There are not guidelines right now describing how trials of cannabis for chronic pain should be optimally undertaken. But I will say that within the Cannabis Research Institute, we do have a research committee. We have begun discussions about ways to provide that guidance for clinical trials, in order to optimize the work that's done. So I think those kinds of guidelines, we do have them in general for clinical trials. We do have them specifically for trials of chronic pain. And we are quite interested in providing further guidance for cannabis trials of chronic pain. So look for something in the not too distant future for information that's at that level of specificity.
Back in the Q&A from Julianne, how do the research findings and medical opinion of the greater international community factor in when deciding about the benefits of medical cannabis on something like seizure disorders specifically? For example, in medical circles, the use of Epidiolex and high potency Charlotte's Web and the like is really no longer something even being debated or challenged. In this case, why can't we drop the word potential in front of the word benefit?
Yeah, great question. And the reason, I think this is an issue that affects products like cannabis, maybe more so than other potential therapeutic agents, because the long history it has. There's a fair bit of stigma around cannabis from many members in the healthcare and the research communities, to be honest. So we need to be bold in what we hypothesize, but we need to be cautious in what we claim. And we need to be cautious because we need to be able to stand behind it with rigorous evidence. So you're right, when you now talk about the use of cannabidiol for management of certain seizure disorders, it's been approved. We have an FDA approved medication. We have well-conducted, robust trials in leading medical journals. It's very easy to counter criticisms and concerns. It's increasingly easy for patients to access these products for those indications. We need to do the same thing with these other indications. We need to get out the high quality research to understand the effects on pain, short and long term, both benefits and harms. We need to understand better how it can affect sleep, anxiety, treatment of substance use disorders. So we need to get this work out there. I think that it is going to happen. I mean, you've heard from so many of the excellent speakers today. dozens and dozens of research studies that are being funded. You heard from CHR, they're putting tens of millions of dollars beneath initiatives to really generate this evidence so that we understand where we can make claims and maybe where those promising anecdotes do not pan out, so that we can give patients and clinicians better information. It's frustrating at this point because as a patient, you may wish that there was better information. I know we certainly do. So we're trying to get it. We're trying to encourage it. There's a lot of other groups trying to do the same thing. My hope is next year, we've moved forward enormously. The year after that, the same thing. And eventually we're going to have these kinds of high quality guidelines for a number of indications so that that kind of guidance is out there.
Question from Tony. Any ideas how we can increase knowledge translation of cannabis research to the public? So much of individual perceptions are founded in anecdotes, self-report, and other reports.
Yeah, it's a great question. And it's one of the reasons for our current cannabis guideline. So that's a 5-year initiative. We have 2 years to sort of create the more fulsome guideline, which will have, we hope, at least 7 recommendations. We'll tackle the issue of inhaled cannabis. The next 3 years is entirely focused on knowledge transfer, implementation, and impact. It's a critical issue. So, for example, the BMJ rapid recommendation that we put out, that's actually available online in an interactive, multi-layered format that comes with patient decision aids for every outcome. Anyone with an internet access can look at that for free. But we have the ability to insert those decision aids into electronic medical records. So they could be used at point of care. When someone came in to see their healthcare provider, they could quickly pull it up. They could even provide it to them before they came into that meeting. And part of the KT efforts that we're planning as part of the guideline is to do some cluster randomized trials where we insert those decision aids, that information, into electronic medical records, in some practices, not in others, and then we look to see, does this help with decision making? Do we see greater concordance between evidence and decision making? Do we get better patient satisfaction? And most importantly, do we improve outcomes? So I think you heard clearly from the representative from CHR this morning, they are very serious about knowledge transfer efforts. They've certainly funded that in our case, and I think it's going to be a critical aspect so that you can, people stop going to Dr. Google and their local bud tender for information on these products, and they have trusted resources that they can turn to that are more likely to give them accurate, reliable information. So a critical issue.
Question from Marco. Should guidelines on cannabis use as therapeutics be more specific to the type of cannabinoid? For example, guidelines should be based on review on the type of cannabinoid, CBD dominant, and exclude THC dominant.
Yes, absolutely. When you do a guideline, you are limited by the evidence that's out there. And at this point, the evidence does not allow us to make recommendations specific to the type of cannabis. What we did do as part of the rapid recommendation, and I encourage anyone that's interested in this to look it up, we turned to our clinical experts on the panel. And we asked them, when you manage patients with chronic pain, how do you address the issue of type of product, mode of administration, dose increase, the proportion of THC to CBD? And they provided us with consensus information that we inserted into the rapid recommendation to provide that kind of guidance, both to clinicians and patients. I'm also familiar with a number of consensus statements that have gone out using what's called the Delphi process, where they get clinical experts together and they say, based on what we know about benefits, harms, different formulations, what is the best advice that we can give to patients and clinicians that are interested? So I know, for example, Hans Clark's group out of University of Toronto has put out one of those papers. There's another group out west that's done the same. So we have some work that's emerging in that area. Do we need trials that then specifically look at these different formulations and different modes? Yes. We don't have it yet, but we do need it.
2 more questions. First from Jeffrey. Now that recreational cannabis is legal, do we know if there is a trend for patients to avoid going through the medical system and instead self-medicate with cannabis from the recreational market? Are we concerned that recreational cannabis retail staff are providing misinformation about potential benefits of the products that they are selling?
Yes to all of those. So the whole idea was there was a fair bit of information to show us, and you heard about this in an earlier talk, that a number of individuals have been using cannabis without medical authorization to manage health complaints. You have a large proportion of individuals that declare themselves as dual users. They will use cannabis for therapeutic purposes, also for recreational. So now that recreational cannabis is easily available and legally so, of course, we have to be concerned about patients pursuing that entirely without any oversight or guidance from a healthcare provider. We have to encourage individuals that are seeking use of cannabis for therapeutic benefits to do so with some supervision and guidance. We know that there's the potential, for example, with interaction with prescription medications, just as one concern. At the same time, we then need to provide healthcare providers with the information so that they feel comfortable providing that guidance. Right now, physicians do not receive training on therapeutic cannabis as part of their undergraduate program. You can't expect clinicians to provide guidance on areas in which they lack the training. So we have to undertake that. There was another question you had, a second part. Can you remind me what that was?
It was about the people, the bud tenders who are going to be selling the retail market. Are they going to be providing medical information?
Yeah, so they're not supposed to. I was asked to participate in a show called Marketplace last year, and of course, as part of it, they got my reaction on live tape to bud tenders providing all kinds of information about the health applications of cannabis, usually preceded with the sentence, "I'm not supposed to tell you this, but." So are people going to receive healthcare information from people that are not supposed to provide it? Yes, I don't know to what degree it's happening, but it's absolutely happening. And part of that is because they're filling an information gap. I think that because a lot of clinicians are hesitant to give advice in this space, interested patients are going to go to where they can get the advice. So we have to provide reliable, trusted resources to avoid that kind of potentially very misleading information, right? Leading on exactly the question that Tony George asked a while ago, are we going to encourage patients to be led by anecdote, or are we going to encourage them to be led by evidence? And I think we should be trying to do the latter.
And the final question, around the belief of higher efficacy than research demonstrates and origins in compassionate care more than definitive research, would you say the availability of medical-like products, such as transdermal patches, in the recreational world promote this false belief that cannabis has greater effects for various medical conditions?
Yeah, it's always very, very difficult when you're dealing with conditions that are largely defined by symptoms to disentangle non-specific from specific effects. And in fact, with observational studies, you can't. And so I absolutely take to heart the experience of someone that says, you know, I did something, I felt much better, therefore I'm attributing it entirely to that product I used. But we have learned time and time again that when we evaluate interventions in rigorously designed trials that include compelling controls where people aren't sure what they're getting, we very often see that there is a large non-specific effect. And what we want to see from a product, if we're going to promote it, is that it has an important specific effect beyond that non-specific. So again, in the one trial I highlighted, New England Journal, children with intractable seizure disorders, 27% of them given a placebo reported a 50% reduction in their seizure intensity, right? So it was, you know, around close to 50% in the treatment arm. So again, if you're just going on observational data, you would say high dose CBD has important effects for 50% of all children. But when you look at the non-specific effects, you see, well, it's not 50%, it's closer to 20%. Still important, but it's important to have those trials so that we can take anecdote, personal experience, and observation and give a more clear definition about how much of that is a specific effect due to the product as opposed to the other things that can affect someone's prognosis in observational studies.
Also put a plug in to the, with respect to the previous question, there is one of the posters from Dr. Vasilia Vastus. One of our poster sessions on YouTube is How Are Canadian Cannabis Dispensaries Counseling Breastfeeding Consumers? So they've done some work on that specifically as well. All right, James, any final thoughts?
Wonderful first day of the meeting. Great talk, Jason. Illuminating as always. I think that what struck me is just how powerful the framework is for evaluating evidence and how the conclusions can change when you incorporate the lens of patient values. And I think that there are now many initiatives for more patient-centered perspectives in clinical research, and that this is just one area where we have to be especially mindful that small effects can be important for these conditions and can matter a lot to patients, and outcomes like quality of life also need to be incorporated in addition to the traditional outcome metrics. So wonderful presentation. Thank you everyone for participating today. I look forward to seeing hopefully many of you tomorrow. We'll be leading off bright and early at 9 a.m. with the risks and harms presentation, the counterpart to this talk today, the other side of the coin, so to speak. Have a wonderful afternoon and evening.